Dear Chairman, dear colleagues, pancreatic non-functioning neuroendocrine tumors are defined by the absence of a hormone hypersecretion syndrome. Approximately 45 to 90% of patients with PNET present with non-functioning PNET. While 80% of them are sporadic, approximately 20% have tumors associated with the so-called MEN1 syndrome. The incidence of non-functioning PNET is approximately 1.8 for females and 2.6 for males. Small non-functioning PNETs, and this means primary tumors less than 2 centimeters in size, are more frequently detected over the last 3 decades than they were in the past. And I will later on show you some data that these small non-functioning pancreatic neuroendocrine tumors are most probably presenting a very specific own entity. We have 2 major staging systems for pancreatic neuroendocrine tumors, the WHO system and the INETS TNM system. In essence, these staging systems are comparable. Again, I would like to bring to your attention the T1 tumors limited to the pancreas, less than 2 centimeters in size. It looks like that these non-functioning T1 tumors are less malignant, less aggressive than other non-functioning PNETs. Pancreatic neuroendocrine tumors account for approximately 16% of all neuroendocrine tumors of the gastroenteropancreatic system, and approximately 50% of patients present either with synchronous or metachronous liver metastasis. So liver metastasis has been recognized as an independent factor of prognosis in management of patients with pancreatic and non-pancreatic neuroendocrine tumors. When we compare the survival of patients with non-functioning pancreatic neuroendocrine tumor to those with functioning secreting neuroendocrine tumors, particularly those with insulinoma, we will notice that the survival of non-functioning tumors or patients with non-functioning tumors is much worse than those with insulinoma. However, compared with other secreting tumors like gastrinoma, somatostatinoma, or PPoma, the survival seems to be comparable. So there is not much difference with regard to survival between the non-functioning and the functioning pancreatic neuroendocrine tumors, except those who are having insulinoma. These are the data of the both staging classification, the INET staging classification and the WHO 2010 staging classification. And you will see that the stage is one of the extremely important factors of prognosis of this patient. While patients with stage 1 tumors in both classifications have excellent prognosis, 10-year survival, nearly 100%. This survival drops significantly in patients with stage 3 tumors, having 10-year survival of approximately 75% and 5-year survival, 10-year survival in stage 4 tumors of less than 50%. And these data are comparable in both staging systems. This is a typical intraoperative finding of a patient with an extensive advanced non-functioning neuroendocrine tumor of the pancreas, occupying basically the whole organ with large regional lymph node metastasis. There are several imaging procedures available nowadays for staging of patients with pancreatic neuroendocrine tumors. Those with non-functioning pancreatic tumors differ a bit from those with functioning tumors. Ultrasonography with Doppler technology is basically the standard, however not much used technology nowadays. Contrast-enhanced ultrasonography, either in 3D technology or even more advanced in 3D navigation technology, intraoperative ultrasound, endoscopic ultrasound in combination with fine needle aspiration, computer tomography, magnetic resonance imaging available in various techniques, MRCP. Then very popular and very sophisticated new molecular imaging procedures like somatostatin receptor scintigraphy and various imaging, molecular imaging procedure based on PET technology. So this is the typical images on ultrasound of patient in pancreatic neuroendocrine tumor, the typical standard ultrasound with a small pancreatic tumor here, the results of the Doppler technology. This is the beta imaging. You see immediately that the demonstration of the lesion and the adjacent structures is much more clear on contrast-enhanced sonography. And this is a most recently introduced 3D navigation contrast-enhanced sonography that can be used either within the liver to assess potentially liver metastasis. Here, a single lesion within a parenchymal phase and a single lesion within a vascular phase. This technology can be also used for determination of the primary tumor. Most of the patients come to us for treatment with CT scans. CT scan is still the gold standard of imaging in patients with abdominal tumors. This is a typical CT scan of a patient with a tumor within the pancreatic head, a non-enhanced phase compared to the enhanced phase. This is a tumor within the pancreatic tail, again a non-enhanced phase compared to the enhanced phase. Magnetic resonance imaging is probably providing similar sensitivity and specificity as a CT scan. Again, various contrast agents can be used. This is a typical MRI scan of a patient with a small pancreatic head tumor. And this is an image of a patient with MEN1 associated pancreatic neuroendocrine tumor. Typically, this patient have multifocal tumors within the pancreas. And this patient, for example, had a lesion within the pancreatic corpus and another lesion within the pancreatic head, pancreatic tail. And you see both lesions are clearly delineated in the second phase of the technique. The appearance of the tumors within the pancreas depends significantly upon the technique used. This is, for example, the T1 weighted MRI of the pancreas. You see quite a different appearance of a tumor within the pancreatic head. And this is the diffusion weighted imaging showing a tumor, the same tumor within the pancreatic head, however, of a bit different appearance as on the T1 weighted technology. Endoscopic ultrasound in combination with fine needle aspiration has been shown to have a very high sensitivity in diagnosis and etiology of a solid pancreatic mass, including of a pancreatic neuroendocrine tumors, and an even higher specificity. So this technology is extremely helpful in those patients with unconclusive imaging results on cross-sectional imaging or functional imaging, and in those patients who are not candidates for resectional treatment, but in whom tissue diagnosis is required for non-surgical treatment decision. Neuroendocrine liver metastasis present a most important factor of prognosis in patients with primary neuroendocrine tumors, not only within the pancreas, but in all other locations. We have identified 3 different types of morphological appearance of liver metastasis, and we have shown that these types not only trigger the decision for treatment, these are the typical and optimal candidates for resection, while this patient, for example, would be a less good candidate for resection, potentially candidate for transplantation. And it looks like that these three different, morphologically different types of appearance of liver metastasis also have an impact on prognosis of the patient. Somatostatin receptor-based imaging has been introduced in imaging of neuroendocrine tumors back in the 90s. This is the typical standard octreoscan scan based on visualization of somatostatin subtype 2, the primary tumor here within the pancreatic head. This is the most advanced technology based on somatostatin receptor visualization, the combined PET-CT technology, and you see that the visualization of the tumor mass within the liver is much better than on standard octreoscan. In addition, we have shown that the evidence of distant metastasis, particularly lymph node metastasis, and bone metastasis is approximately 30% higher if one uses PET-CT technology compared to somatostatin receptor scintigraphy. This is a CT scan of a patient with liver metastasis, not really clear information what's going on within the pancreas and within the peripancreatic area. The PET sequence shows us clearly significant uptake within the liver, uptake within the peripancreatic lymph nodes, and the uptake within the pancreatic tail. And this is the fused image of the same patient, delineating exactly where this uptake is localized within the abdomen. On sagittal image, you see clearly not only a very extensive metastatic spread within the liver, within the abdominal lymph nodes, but also lymph node metastasis within the supraclavicular lymph nodes. Nowadays, we detect tiny bone metastasis in a large number of patients in whom in previous studies based on octreoscan, these metastases were not evident. For example, in this patient with a large tumor within the pancreatic tail confirmed on dotatate PET-CT. You see also a tiny hotspot within the bone, not seen on standard CT scan. The biologic relevance of this tiny metastasis remains unclear. However, for patients who are, for example, candidates for liver transplantation, these findings are crucial, since these findings would exclude a patient from further evaluation for liver transplantation, and most probably these findings would also trigger early tumor recurrence. Now, coming back to the T1 tumors, how we treat this patient, for example, with a tiny tumor, T1 tumor, non-functioning T1 tumor within the pancreatic head, confirmed on PET-CT. Do we resect this? Do we observe this patient? I think Professor Jagannath will give us more information on this. In these situations, for example, a proper staging of a patient is extremely important, since it really triggers the decision for treatment, surgical versus observational treatment. Sensitivity of molecular imaging modalities is very high in G1 and G2 pancreatic neuroendocrine tumors. It seems that 68 gallium, DOTA-TOC or DOTA-NOC, PET-CT has the highest sensitivity of all of these very sophisticated imaging techniques for less well-differentiated tumors, for those with Ki-67 more than 15%. However, most probably the standard FDG PET is the better and more sensitive imaging procedure. We have shown that the results of DOTA-TOC PET-CT not only allowed us to stage the disease properly, but has also impact on the treatment decision. We have performed a study on patients in whom standard imaging results were available. All these patients underwent also PET-CT scanning, and in every third patient, our initial treatment decision has to be revised, either in terms of change in surgical strategy or in change to non-surgical treatment. So how would you nowadays suggest for a patient with a non-functioning pancreatic neuroendocrine tumor, how the staging should be carried out. The initial staging procedures are without doubt the contrast-enhanced ultrasound, CT scan, or MRI for the primary tumor, and diffusion-weighted MRI for liver metastasis. 68 gallium dotatate with available with various conjugated peptides is nowadays the gold standard for imaging of patients with neuroendocrine tumors and should be implemented in our staging. For patients with inconclusive results on cross-sectional imaging or functional imaging, and for those patients who are not candidates for surgical procedure but in whom a tissue diagnosis is required, endoscopic ultrasound in combination with fine needle aspiration biopsy is extremely helpful. So to conclude, TNM stage of a non-functioning pancreatic neuroendocrine tumor is an independent predictor of survival. The type of liver metastasis is predictive of prognosis and triggers our treatment decision significantly. Somatostatin receptor-based PETs is the most sensitive imaging modality for G1 and G2 non-functioning pancreatic neuroendocrine tumors. For those with higher Ki-67 index, most probably FDG PET is the better solution. A combination of morphologic imaging and functional imaging, so-called 68 gallium dotatate PET-CT, enables the most accurate staging. And we should keep in mind that staging should always be combined with grading. Means the decision how to treat our patient should be based on one side on the staging results, on the other side on the grading results. Thank you very much for your attention.